Good afternoon, everyone. Welcome to our webinar on the next era of assessment, focusing on equitable care of patients and capitalizing on precision education for learners. My name is Sanjay Desai. I'm the moderator for today's live panel. I'm very excited to introduce our guests in just a moment. I am the Chief Academic Officer at the American Medical Association. I want to tell a little bit about the context of this webinar. As part of the AMA's ChangeMedEd initiative, we have a new strategic focus on precision education. The AMA has supported a supplement in April 2024 in the 2024 issue of Academic Medicine that's entitled The Next Era of Assessment, Advancing Precision Education for Learners to Ensure High Quality, Equitable Care for Patients. In this supplement, authors compel readers to consider the next era of assessment that places less focus on how assessment is done, for example, tests or work-based assessment, and more focus on why it is done to ensure high quality, equitable care for all of our patients. This vision stems from competency-based education, which places the focus on ensuring training outcomes prepare graduates to provide the care that patients need and applying a learner-centered approach to education. The supplement also promotes precision education specifically as an approach, as a tool that can help meet learners where they are in their development and helps them take specific next steps needed to continue their development in an individualized way. This webinar will feature two of our guest editors from the ChangeMedEd supplement in academic medicine and explore how the future of assessment and the meaningful use of learning and data analytics in medical education can focus on ensuring high quality, equitable care. To review our objectives for today, by the end of this webinar, our participants will be able to, number one, discuss what a future era of assessment that focuses on ensuring high quality, equitable patient care can and should look like. Number two, examine the components of precision education and how they can be used to catalyze learner development. And number three, outlining emerging types of assessment data, including assessments that can be gleaned from the EHR, metrics harnessed from large public databases and data visualization that can enable and support decision-making. So with that, it is my honor to introduce our two guest speakers today, our co-editors of this issue in academic medicine. First, Dr. Sally Stanton. Dr. Stanton is the Associate Dean at the University of Cincinnati College of Medicine. And second, Dr. Danielle Schumacher. Dr. Schumacher is a tenured professor in the Division of Emergency Medicine at the Cincinnati Children's Hospital Medical Center. Thank you both for spending time with us today. I want to review a little bit of housekeeping before we kick off. The first is that during today's webinar, please submit your questions in the chat box. We encourage lots of questions. We're going to try to get to as many as we possibly can during the presentation. And then following the webinar, please take a moment to answer our short survey. We are trying our best to continue to provide valuable information for everyone, and your feedback is very, very helpful to inform our future events. Please click on the third button below at the end of the presentation to access this survey. Lastly, this event link can be used to access this webinar on demand and read the transcript as well. So with that, I'm going to pass it on to Dr. Stanton.
Thank you, Sanjay. And I want to acknowledge our other co-editors with this. We had Jesse Burkrafel from NYU, and we had Carla Pugh, who is also working on this with Dan and I, and so we appreciate their work as well. So I just wanted to acknowledge them. So I'm just going to tell you a little bit about the history of the supplement. The first part is the why, like why does this matter? And it really was based in assessment, with the sense that assessment drives learning, drives training, and it really kind of drives the behavior of what we do or what people do, because it is measuring the performance and kind of saying this is what's important. And so that's why we were really focusing on assessment. This supplement built on a prior supplement from Dan Schumacher and others, which looked at entrustable professional activities, which is a kind of a different framing of how to assess trainees. And then it also built on the next supplement, which was sponsored by the Macy Foundation, which was bias in assessment, which is an important thing to be thinking about as we're measuring trainees and learners as we go. And so we really kind of built on that foundation for this supplement and worked with a bunch of great authors to make this happen. And I'm going to kind of throw this to Dan to say, so what's the next era of assessment, Dan?
Yeah, so this actually, this picture that you're seeing is from the cover of the supplement. And I was really taken by a paper that came out a couple of years ago, written by Kees van der Vleuten and Lambert Schuworth, who are really people that have written a lot of the history of assessment in medical education so far. And it got me thinking about what the next era might be. So I'll just review quickly the three eras they talk about. They talk about assessment as measurement, which is really what we think about 1950s, 1960s, the birth of multiple choice exams. And that's sort of like, featured in this, like the pictograph on the far left here. And that, really assessment as measurement was king at that time. I wouldn't even say queen, because I think we were living in a paternalistic world back then. And that sort of gave way to a next era that is an era that I think we're all familiar with, where CBME really took root. The idea that you should be assessing people in the workplace, in the work that they're actually doing, and that assessment is judgment. Sometimes narrative comments are important. Matter of fact, a lot of people think they're quite important. And this is also where the idea of clinical competency committees sort of came from, right? That humans should get together and make sort of like decisions about whether or not someone is developing okay. And that gave rise to a third era that we are also currently in, that a lot of times people will call programmatic assessment. The idea that we get the best picture of someone's performance by assimilating lots of different types and sources of data. Exams are important, observations are important, written comments are important. You get the best picture when you put them all together. So those are the three eras. And what struck me about it is that all three of these eras really focus on how we do things: exams, observations, forms that you would fill out, narrative comments that you would write. And it got me thinking, the focus has never really been on why we do assessment, at least not in how Dr. van der Vleuten and Schuworth characterize things. That really got me thinking about what a next era might be defined by why we do it. And this is where we're coming at the idea of why, to ensure high quality, equitable patient care. And so this is one of the articles that sort of frames this supplement from this idea of envisioning a next era of assessment that really leans into this why. And then there's a second article. I'll throw this back to Dr. Desai, that also frames what do we mean by precision education. And then as the webinar goes on, we'll sort of continue how we have put these two things together throughout. We'll highlight some of the papers.
So this is the paper that we were just talking about around the conceptual model that Dan was just describing. And I'll take just a couple of minutes to walk us through what we've done. And this development of this model, just to give you some context, is multidisciplinary. We had many people come together that have worked in this space for a long time, and others that are fairly new to it, to try to think through what is this future, putting in, as Dan has eloquently described, this current phase of assessment where it has multiple inputs, taking advantage of the abundance of data that we have. This wheel will look similar to many of you because it looks somewhat like a PDSA cycle, but even more like the cycle for Master Adaptive Learner. And this is built upon that. It's also built upon work that's been done in precision education that's been published in academic medicine as well by Dr. Burke-Raffel and Dr. Triola. And the idea here is that this precision education loop, the opportunity to learn about people and provide lifelong learning, centers on can be applied, to different levels of learners. So it can happen to the person. So if you look at the middle of this graphic right now, there's an individual. There's also a program, that's the collection of people, and then there's an institution. So keep in mind, this can happen for any level of learner in the system. And around this entity that is learning, if you look at about 10 o'clock on this wheel, there are inputs. There are inputs that come in for this particular, we'll use an individual as an example. Upon those inputs, and those are data from the learning management system or from the EHR, from a test that's been taken, analytics are performed. Those analytics that are, the performance of those analytics lead to insights about this individual. From those insights, we plan interventions that are actually personalized, targeted to what we want to address based on those insights. Those interventions create learning. We assess the learning that occurs, and that results in outcomes. And those outcomes then lead to an adjustment in the cycle and refreshment of the cycle that continues forward. In the center of this, and this is really the two things that are different than that master adaptive learner cycle from the precision education model, are number one, that the top action of analytics. So really taking this opportunity to use analytics to apply against the inputs there. But really it's the center where data is highlighted here. And the idea here is that we are taking advantage of the abundant data that are available for any one of these entities in the middle, whether it's about the person, whether it's about the program, or whether it's about the institution. The reality is that those data exist in fragmented compartments across the vast medical education ecosystem, and they're governed by different rules, and they are owned by different people or different entities, and they're used in different ways. So that's one of the challenges of this model, is how do you use those data, again, as Dr. Schumacher just said, to and assemble them and synthesize in a way to drive and power this cycle. If you go to the next slide, please. So here we've just described that the middle of this is data. There are two. You can click again. The two wheels in the middle that I'd like to describe briefly are from these data. There's another ring outside of it that we're labeling as entities and products in our conceptual model, and that's the notion that these data are not the way that they are consumed are through entities and products. And we can use the health system as an example. The health system has data on patients. The entity is the health system in that, and the product would be the EHR. The EHR is the product that contains and houses that data. So again, there are an abundance of data, but these data are consumed through various entities and products. And in here are dotted lines because the way that they are consumed needs to be developed. The rules, the governance, what we're calling principles and standards around the use of these data and the processes by which they're exchanged, shared, replicated, scaled needs to be needs to have thought put into it. And these principles and standards, we believe, is an important next step in developing these models and systems of precision education. And it's easy to imagine why this is so important, because for us to ensure that there is equity in the process, to ensure that they achieve the goals of an educational system, such as learner agency, is important, and to ensure that they actually create processes that harmonize within the workflow of a physician is also equally important. And you can see on the left and right examples of the entities and products that that one might invoke in such a model. Next slide, please. And this is the final slide. This slide just demonstrates that this model is not static at one point in time, but is really grounded in longitudinal use and bidirectional flow of data. We believe the precision education model, one of the advantages of it is that when the data are collected and used in a way for the development of a person, a program, or an institution, that by allowing those data to flow bidirectionally, we can learn from experiences even when they're outside of the scope of one compartment of learning. Using the individual again as an example, if somebody graduates from medical school and goes to residency and then goes to clinical practice, it would be very helpful for us to understand the outcomes from clinical practice, which would then inform quality improvement in the educational model at the medical school from which that person has graduated. So that's just one example of how data flow bidirectional data flow is very important to the conceptual model of precision education. And this slide again is attempting to convey this process over time. Next slide, please. I think that might be yes. Dan, I'm going to turn it back over to you.
So Sanjay is talking about this idea of inputs leading to insights, leading to interventions, leading to outcomes in this sort of like precision medical education model. I'm going to give you an example from one of our papers of what that might look like. This team here is a team that run an internal medicine program actually across the street from me, where Sally is at the University of Cincinnati. Some of you may know Eric Worm and his team and their wonderful work over there. They designed something that they called an ambulatory long block to emphasize the continuity of care with patients in the clinical learning environment. Before this innovation, they were like a lot of primary care training programs in pediatrics and internal medicine, very inpatient focused, with only a half day a week dedicated to ambulatory practice. And that led to dissatisfaction and subpar clinical and learning outcomes. So to address this, they developed this year-long continuous ambulatory group practice from the latter part of the second year of training into the third year of the 3-year internal medicine residency. And each resident gets a patient of approximately 175 to 200 patients that are seen 3 half days per week. And when they're away from the practice, like when they're on an inpatient rotation, they're still responsible for this panel of patients through the EHR. My chart messages, needs of the ordering things, needs of the patients, and they develop clinical performance metrics that are reviewed at weekly meetings, and residents receive personalized feedback on their contribution to these outcomes. And I think this really shows how precision education and assessment can come to life. So if you showed the next slide here, this shows clinical performance for selected measures for a single resident. On the left-hand side there, you can see some example measures. They actually have a longer list than this. Just for the sake of simplicity, they prepared this down for the article. And the target performance for each measure is compared to actual performance of the resident at a given point. And the target is determined by a multidisciplinary team that helped to lead this ambulatory long block clinic. In addition to the target improvement goal, the residents also see like an absolute improvement from the first time point that they took the panel to where they are right now. This is really important, right? Because you can imagine inheriting a panel where maybe the measures weren't being met that well. And so what's really important for you as you're taking over that panel coming into this ambulatory long block is that your delta is there, right? That you are showing some improvement toward the target, even if you're starting with people that are pretty far from the target, really giving you credit for, for the work that you're doing if you inherit a panel that's subpar. So the unshaded background here indicates that you're meeting a target. The shaded background indicates that you're not meeting a target. And the final column indicates if either or both of the performance and improvement targets are being reached. The bold numbers represent actual measured performance. So I think that this really shows, right? This provides input to the residents about their performance, that gives them insights about how that's going, that can drive interventions that can hopefully change outcomes in a successive way. So with this example, I'm going to turn it over to Dr. Santon for a few other examples from the papers.
Sounds good. So I'm just going to remind people there is a QR code at the beginning, and we will show it at the end again. All of these are available as open access on the Academic Medicine Supplement website. And so you can get every one of these articles and do what you want with it as you choose. And then the other piece of this is these two first articles that we're discussing here, we've asked the authors to come and do a webinar themselves to really kind of talk about the details, because I'd like them to do the just work on this, because they've done so much work with this. And so Dr. Garibaldi and Dr. Warm will both be joining us in June, or joining Dr. Desai in June, to talk more about the details of these two articles and the work that they've done. So as Dan and I and the other editors put this supplement together, we really reached out to kind of our social networks to say, our professional networks, like, who's doing precision education, and how can we take the sense of assessment and precision education and meld them together in a series of papers that will help people understand what we're talking about and to really move the field forward. And so this is a really nicely worked paper where Dr. Garibaldi and Desai brought 3 different precision education use models together. I'm going to talk very briefly about the first one. I'm going to talk a little bit more about the second one. I'm going to kind of leave the other one off, but feel free to look at the article. And so this is 3 use cases from on-the-ground initiatives. And let's take the next slide. And so the first one, again, you'll hear more in June about the details of this one. But here the input, this is GEL, which is the Graduate Medical Education Library at Johns Hopkins in internal medicine. And so GEL takes, the inputs are it's really cool, the things that they put together. There's a tracker on residents if they're willing to do it. And so they can see where they are. Are they at a patient's bedside? Are they doing something else? And so it's called RTLS data. And then they're also doing clinical skills assessment. And so they show them a patient. They have to do a physical exam, a history and physical, and decide if they know what the diagnosis is. And then they match that with a series of surveys. And so what they're doing is they're trying to link all of these pieces of information for inputs. And then from those inputs, the analytics are done, and then there's going to be insights, right? How much time do residents really spend at the bedside? Does that mean they're that they've got better well-being? How much time do they think they spend at the bedside? Do they have better well-being? And so from all of these pieces, you can see the cycle happening of the data comes in, analytics are done, insights are made, and then hopefully that gets then fed back to either the program. Nobody knows how to do a physical exam, or people aren't spending enough time with their patients, or not completing their charts. And interventions are done to try to make a difference and make changes. And then we come back and we look at the outcomes and the interventions that are done. And so through this cycle with GEL, you can see a bit about how precision education is working. Next slide. So this is a second example. And so this is happening at Transition to Residency Advantage program. This is funded through Reimagining Residency through ChangeMedEd, the AMA, to Dr. Abby Winkle and her team, and the NYU team. And so they're specifically looking at this space from, match to starting internship and into internship, recognizing that our trainees really need information to help them get better, and then need kind of insights in this whole cycle of doing a precision ed cycle. And so what they're using learner data comes into a coaching relationship. So it's the learner and the coach. And so these are mostly fourth year students to begin with, and then as they go into internship. And so the learners and the coach are looking and reviewing the data that the students have. And from that data, they are doing an analysis and having insights. Like, as I go into my OB internship, or as I go into my emergency medicine internship, what am I going to do to make myself a better intern? What are my gaps? What are the things that I can do? And all of this is done with the partnership of a coach at my shoulder. And so from those insights, the student will then have interventions. How are they going to approach it? What are they going to do differently? And then outcomes. What are the results of the things that I have done? And then they come back through the cycle again. So what's happening with this process is that there are multiple coaching sessions where there is data, analytics, insights, interventions, and outcomes, so that every student is creating their own kind of master adaptive learner or precision education cycle to improve them, so that when they start internship, they'll be ready. And this is the Transition to Residency Advantage program. I think it's really cool. It's such a great way to think about doing the transition to make us better. And so it's a great kind of use example. Next slide. So, as I said, we were looking for kind of ideas of how we might, of ways in which precision ed is out there. And this is Dr. Carla Pugh's work. So she does haptics, and haptics are kind of the science of touch, I guess is what I would say from a layman's point of view. But they have haptic models like for a breast exam. They have haptic models for thyroid exams. There's some haptic models for like the tension and laparoscopy. And so what they're doing is that they're looking at the haptic data to create insights into how things are done. And so there's a couple of papers here, one of which is a breast exam paper, where it looks to say, I don't know how many of you are physicians or women have had breast exams, but there's a depth and a speed and a direction and a place in which you do a breast exam. And what they're finding is all of those make a difference as to whether or not you'll actually find the nodule. And they're doing that through simulation. And so they're using literally the hand sensor data to help people guide to be better measurement or better assessors measuring things or physical exam findings. Next slide. Another example of this is thyroid palpation. And so in the old days, we used to have standardized patients, and you do a thyroid exam on somebody. That's the checklist. And then we started to be a little bit more clear about what needed to go on the checklist. Did you actually feel the thyroid cartilage? Did you look at symmetry? Those sorts of things. With haptics, we can literally put sensors on thyroid models on our neck, and we can measure whether or not they're touching the right thing. And so before we used to kind of watch somebody do a breast exam or an abdominal exam and we'd say, yeah, we think it's good. But now we actually have real data, which can provide good feedback to the residents or whoever's doing the exam to improve their performance. And so that's kind of the haptics part of precision education. Next slide. And so, Dan, what I'm going to ask you, so this is where we're going to kind of talk about what are some of the kind of subtleties of what we were getting into. What are the things we need to pay attention to?
Right. So these two papers are both perspectives pieces from the lens of trainees and from the lens of equity. And you might think, well, geez, these are so foundational. Why are you putting them this far into the webinar? And we agree they are foundational. Actually, if you were to pull up the supplement, there's some of the earlier papers. But we wanted to give you the context of what we were talking about to be able to sort of like, before we sort of introduced them here. And they speak to a couple of key things. The trainee paper by Dr. Kayla Marcotte really speaks to the importance of transparency in the development and implementation of everything that we are talking about. And I think that's really key. And Sally mentioned a Macy Foundation's funded supplement from late last year that also really spoke to the importance of transparency at getting at equity. So the other paper here did focus on equity, the paper by Dr. Javid Sukhera. This paper provides actionable recommendations on how precision education may advance equitable assessment. And first, precision education implementation may include democratizing access and ownership while enhancing while enhancing literacy and transparency. An open and transparent access to both the data and the technology for precision ed has the potential to enhance precision by fostering greater participation, rigor, and potential innovation. And transparency also safeguards against the use of assessment data for equitable purposes. This paper speaks to the trainee paper in really highlighting how precision education implementation must be co-created with diverse groups of learners. Just really, really key. Because that will help empower them if they're given an opportunity to participate in the development, application, and implementation. And overall, really, this paper and the trainee paper both really speak to the importance of a participatory approach to accomplishing everything that we're talking about. I'll hand it back over to Sally.
Sounds good. And so you've heard, as we've kind of talked about some of these papers, that precision education can happen at different levels. It can happen at the learner level. For example, the transition to residency assessment, where it's the learner, like the resident or the intern, who's looking at their precision education data. And that then provides feedback in the cycle to the learner themselves. It can also be done at the program level. And so the GEL program is looking at a program level of how much time do our residents spend in the room, how good do they do a physical exam, what kind of well-being is it, and so that is providing insight to the residency program to help improve their program itself. It's also possible to be at the macro level, like all of medical education, like all medical schools, all residency programs. And so this paper really kind of talks at the kind of meso-macro level using some national data sets of Medicare outcomes, using some other data sets of practice, which comes out of the master file, and really trying to look at, are there insights to a bigger section of medical education, either all medical schools or all internal medicine residency programs. But it is to say that all of the precision ed cycle can happen at different levels, and that often they're informing each of the other levels. So if you're looking at just the learners, that still is informing your program. If you're looking at the residency programs, that's informing the systems itself. But thinking about it in all of those settings. And this paper really kind of gives a couple examples in that case. Next slide.
So the final paper that we're going to talk about before we transition to some concluding comments and getting to some of your questions is this paper by Brent Thoma and colleagues. I really like this idea. They speak to secondary data uses. And what they mean by that is, so if you think about learner-associated data, as they call it, we think about formative assessment and summative assessment. But there's secondary use there that you could do for those types of things that are focused on trainees, right? You can think about using it for program evaluation or educational quality improvement or even faculty development, right? How are the faculty completing assessment forms? That you could, you give that not only to the trainees, but you can use that to help improve how they give assessment in the future. And then there's also patient-associated data, right? And I think this is really key, right? This some of the work that I've done outside of this supplement, right? That there's a lot of things in the EHR that are meant for billing and documenting clinical services that are rendered, but you really can pull that to give some idea of the quality of care that's being provided as well. And that's what they mean by sort of secondary uses of data. And in this paper, they give the example of SIMPL, the Society of Improving Medical Professional Learning. It's a nonprofit collaborative that has hundreds of training programs in dozens of networks. Their mission is to develop, disseminate, and maintain an infrastructure needed to support educational quality collaborative platforms. And as part of this work, they are looking to use and deploy AI models. So what might that look like? Because this also applies to learner-associated data, some of the precision medical education things that we're talking about, and patient-associated data, which also gets into precision education, right? As we bring these together. So SIMPL's just continuing to pull on this example. Their infrastructure, it's app-based on on like an iPhone or an Android. They use EPAs. They have over 500,000 EPA assessments in all of the sites that are using their data. And while it's primarily used right now for formative assessment, they are also using it to develop some AI models that could be used for precision education purposes. So you can think about predictive performance expectations models, right? Based off of the EPA data that's filled out by someone, can you predict the likelihood that they're going to be determined, ready for unsupervised practice with a next assessment? The SIMPL app also has narrative. And you can imagine using natural language processing to sort of like ferret out, is there bias in the comments that faculty are writing or not? And how can you use that to give feedback to improve the faculty narrative moving forward? To just give some examples, right? This is examples of how you can really do precision education and feedback, even in the moment, in this app. So very interesting paper, really great model in SIMPL. So with that, we've got to the end of the papers we're going to highlight. So I believe I'm turning it back to Sanjay to give some concluding thoughts here.
Yeah, thanks, Dan. Thanks, Sally. So maybe I'll just talk very quickly about some next steps that we're thinking about in this space. But I do want to quickly transition to some Q&A because there are a number of questions that have already been submitted. Again, a reminder to everyone, please submit questions into the chat. We're happy to use those for our discussion. One comment I wanted to make, building on the examples that you both have provided and the potential of these innovations in this space, is around what are some immediate next steps. So I think beyond the innovations which you both have described or started to describe, what's clear is that these innovations are occurring. And one of the important next steps, if you remember the conceptual model, is around principles and standards. So how are these data consumed and how are they used in these models? And this is important because if we don't think carefully about the principles and standards, then what will likely happen as a default feature are that these innovations will start to occur only in places that are heavily resourced, and they will likely sit there, and they will sit there with guidelines and guardrails that those institutions create on their own, which we hope and trust will be safe. But what would be more aspirational for the future, especially recognizing medical education is a public good, is that these innovations can be scaled, replicated and scaled across the country. And to do that, it requires some synthesis, agreement, consensus around how that can happen. So we're using the words principles and standards almost as the nomenclature, although those terms are highly specific. We're using them a little bit loosely. What we mean are some understanding of how these data are to be shared and governed, so that another institution that may not have the power or resource to innovate against it can actually use this information. The other reason it's really important is that we know physicians move. They move between medical school and residency. They often move after residency and sometimes during practice as well. And if we really want somebody to have the benefits of lifelong learning powered by precision education, then that data needs to move with them in a way that can continue to inform them and their development through their entire career. So I think for us, that's an important next step, is to think about that in addition and in parallel with the innovations that are occurring on the ground, as you guys both have eloquently started to describe. So thank you both very much. I have, there are questions in the chat. I have one I'll kick us off with and then go back and forth between the audience and my questions. But you started, Dan, with the framing of the idea of competency-based medical education and how, that is what we want. At the same time, CBME is a future state that has been a future state for a long time because we've been thinking about this for decades. So in your view, how is precision education going to position us to break through some of the challenges that we've experienced with implementing CBME?
Yeah, I think it's a really good question. I think that we have not fully realized at a large scale the promise of CBME, because I'm not sure that people even know. They think they know what CBME is, but I'm not sure that people actually know with some precision. So I boil down CBME to two words. I think it's a patient-focused and learner-centered way of doing education. I think it's that simple. Those two words. So the learner-centered piece, I think, really speaks to precision education. CBME seeks to meet learners where they are in their development and help them take their next steps in their development. And obviously, you're going to do that in a better way if you are precise about where they are at and precise about what they need to be doing for them, individualized, to help them take those next steps. And I think that precision education is the way to do that, right? I mean, this really what it's trying to do, right? Is meet people where they are, help them take the next steps in their development by giving them the feedback that helps them take those next steps, and the data that helps sort of inform where they're at and where they should be going. So to me, it's a perfect way to realize the promise of CBME.
Yeah, and hopefully this accelerates it as you described. Another, Sally, I'm going to go to you for a moment. Another topic that was discussed today, and you guys have published articles on this, is the power of precision education related to equity in medical education. So I'm curious, beyond even the paper, what you see as the potential for us to, again, use this inflection point as an opportunity to help us achieve better equity.
Yeah, I think that's important. And I think that when I think about equity, there are kind of two frames for it. One is that there's bias, right? Is that in a lot of the data that we are collecting, there is bias in terms of race, ethnicity, gender, other demographic or characteristics. And so that we don't always score or rate trainees or people in the same way if they have different characteristics. And so I think the hope is that through some of these assessments, as we look at the data and look at the way that we're creating data, that we can create a more equitable assessment, a less biased assessment. And I think that there the devil is in the details, right? As we talk about AI and other things, is that if the original data has bias or has differences, then you will see it in the next level of data. And so it's really that paying attention to the data that's there. I think there's also a sense of that one of the opportunities of precision education is that everybody gets to great, is that by having a better sense of what every trainee or every learner, every physician is doing, we all get better because we've got good informed information. And so that kind of gets it to the, I love the picture of the baseball field, right? Where you see the equal equity, but in the end, you see the fence gone and everybody can get what they need. And so I really like the sense of that precision education will help all of us get better in our own individual place, regardless of who we are.
I appreciate that, Sally. I'm going to take a couple of questions from the audience and then come back with some of mine as well. Bill Marks, this is actually for me. I'm going to start as a response, and I'll turn it over to my colleagues as well. Bill Marks asks, how will precision education changes apply to maintenance and certification requirements? And I think that's a really important question. So the way that we've conceptualized precision education is to enhance lifelong learning. And we know that the long arc of learning occurs in practice and not in medical school or in residency. It's also the part of our journey that's least structured. And so MOC is designed, really, the intent of MOC is to ensure that we continue to participate in lifelong learning. I think the way that most of us have experienced this is one that doesn't necessarily achieve that goal effectively, because it may be too administrative, it may be too bureaucratic, it may not be aligned with the patient care that you're actually delivering, or it may not be relevant for the patient care you're delivering today or tomorrow or in approximate time. So there are a lot of barriers to that, and I think precision education is a real opportunity here. In fact, we have innovations, we didn't describe them in this webinar, but we have in other settings where we've developed models, or models have been demonstrated that actually take an assessment of the patients you will be seeing in your clinic, and then use that to deliver personalized educational content that is patient relevant. And in the pilot of this type of innovation, it's been received very well. These are, again, like most of what we're describing, nascent in their evolution, and there's a lot of work to be done. But I think from that, the promise of maintenance and certification, precision education, enhanced maintenance and certification, I think will allow for patient relevant, in workflow aligned education that should make this, I believe, more joyful. So I think that's a real opportunity in this space. But let me ask Dan and Sally if you guys have other comments on that particular question.
I think it's important. I think that that physicians sometimes have blinders to what they're competent and non-competent in doing. Dan and I have had some conversations this week, and that providing good feedback to say, hey, you're not quite up to date, or perhaps you haven't done this important procedure in a long time, helps us to kind of reach out for help and to improve ourselves so that we're going to keep improving our practice.
And I'll mention, I think the Specialty Society that's actually quite ahead on this is ophthalmology, who have been using the IRIS registry to deliver identify gaps and deliver education. So there are real-world examples of this as well. I'm going to move on to some other questions in the interest of time. So there's one from Jane Miller. Dan, I believe this is for you. This is how would this approach fit into the history of well-designed portfolio assessment models? Bidirectional data flow is a key feature of these portfolio assessments.
Yeah, I think that she was talking about Dr. Worm's ambulatory long block data. And so it's important to note, actually, that I'm presenting a snippet of their total program of assessment. Actually, some people have said that they have the best program of assessment that they've ever seen in a training program, residency training program, and I think it's true. So they use this ambulatory long block data along really a plethora of frontline EPA-based assessment data that they use some learning analytics to sort of like determine if people are at the expected trajectory and place based off where they are in training or not. And they also get some really rich narrative comments to support all of these quantitative data that they have. And they have a CCC that is really invested in discussing all of this data and coming to the right decisions. So I think what I'm presenting is a piece of a really well-designed portfolio.
And having seen the CCC and learning about the CCC at Cincinnati, I think it's an important comment to make, which is that these innovations are not standalone innovations. They must be embedded in culture and process that allows them to deliver the benefits that they can deliver. And so the CCC process, I know at your institution, is one that is robust and is able to take these data and use them in a way that, again, they're not plug and play. They have to be surrounded and embedded in an environment that is nurturing to these innovations as well. We have a question also from Sydney Weissman. Sally, I'm going to ask you this question, which is that the outline of actions are clear, but we have thousands of, and this is because you've done so much work in faculty development, but we have thousands of clinical teachers and evaluators. In residency, residents who are learning serve as the core teachers frequently of medical students, and learners are teaching learners, which is the point here. So how can we have precision without having standardized teachers?
Yeah, it's the struggle, right? Is that we have hawks and we have doves. It's called leniency and stringency. And so, so there's a couple ways for this. One is, again, pulling from Eric Worm's work, and it's something that I had also done at Virginia Commonwealth. You can actually correct for people. So I'm a hawk. I'm almost always a hawk. And you can actually correct me for myself. So that if I'm always like off the scale as a really low number, and then I all of a sudden am giving a higher number, but it's still lower than the mean, you can actually correct for ourselves using an expected score. And so again, Eric may talk about this, but they created an expected score for their residents, Dr. Worm has, which takes into account which rotation, which faculty member, where in the year they are, and other things. And they create an expected score so that they know whether or not the resident is kind of on target or not on target based on all these factors. So I think for those of you who have a lot of data and the data is historical, try to create an expected score. Look at the hawk dove piece of it. You can try to train your faculty to be less hawkish or less dovish, but the majority of the papers show that that doesn't last for very long. It lasts for a couple weeks, maybe a couple months, and then people go back to their true nature of being either a hawk or a dove. I think the other piece of this that we're really kind of advocating for, and Dan and even the GEL, a bunch of these projects are looking at it, is multiple sources of data. Is that if you're bringing in, patient assessments and nursing assessments and resident assessments and student assessments, and then you're in the AHR and looking at outcomes. Did they order this? What does their history and physical look like? Can we use AI to score the clinical reasoning on their history and physical? All of these things are in the process of like we know what people are doing. And so it's possible to kind of bring all of those in. And so that programmatic assessment of having all of the data in multiple forms may help to address this sense of too many people assessing. I also think that it is helpful sometimes to have what I would call a micro assessment. And so it's something like, what we're doing currently is we're doing milestones or we're doing sub-competencies, right? And so we might say something like, did they recognize the patient was sick, right? That would be an emergency medicine one. But we can ask something very specifically of, did they see the blood pressure? Did they act on that blood pressure? And to be doing kind of these micro pieces of responsibility that would be much easier to say yes or no, so that you're not relying on the hawkish or the dovishness of the faculty or assessor, and really trying to get into the granular detail of yes, no, that this was happening. But it's a good question. We keep working on it.
Yeah, no, but I have a question for both of you that's follow up to that. I appreciate the notion of high frequency, less effort assessment that in volume can give us signal. But the question I had is actually around the second comment they made around programmatic evaluation and the outcomes data. So there, again, if we use an abundance of data and we tie it to outcomes, which we would like to do because we can help deliver really precise development needs for a particular physician, many have raised concern around that, because now as a physician, if you're going to be collecting these outcomes data and then sharing them back, I know it's meant to be formative for me so I can develop, but at the same time, these are patient-related outcomes data about my performance, and that comes with other sensitivities that I may not be open or welcome to, be as welcoming to know that you are monitoring. So this big brother effect related to things that are perceived as highly sensitive, how do we navigate that? I think, and I'm bringing you into this as well, because you mentioned this is the third era of assessment, which has these outcomes-related multi-data point inputs that are necessary.
Yeah, I mean, I think I would pick up on one of the things I said that two of the papers spoke to, the idea of transparency, and I think that really is key. And I think that also having the key end users, at the table when you're designing, implementing, and improving things, I think is really key, right? I think that part of what you're getting at, right, is sometimes we double barrel the use of things, right? We say, oh, this is just for your formative feedback, help you grow. But actually, now that we've gone down the road a little bit, we're actually going to use it because we don't have enough data. We're going to use it as a summative measure for you as well. That kind of stuff, in my opinion, is just not the right thing to do, right? If you tell them you're going to use it formative, it really should only be formative. And there probably are, and probably a lot of things should focus on formative. That should probably be the predominance of our focus. But some things have to be summative because we have to ultimately decide if we're going to progress people, graduate them, move them along, certify them, credential them. These are all things that we have to do in the real world, right? So there have to be summative moments. But I think that we should just be very clear about, the data that we're using for that and how we're making those decisions. To me, really, transparency is the key to all of this.
Sally, I don't know if you wanted to add to that.
So, I think we start medical school, and the first 2 years of medical school are kind of pass fail in some ways, and then they get into the clerkship, and it's all about grades, right? And so there is this lack of willingness to, on a student's part, it's hard, right? I don't want to say I don't know something because maybe that'll affect my grade, and so I do think that we need to change the foundation of our education system. So it is about precision education or master adaptive learner or growth mindset, and that our current process of normative grading and difficulty getting into residency is really problematic.
Yeah, and I think that there's this, my mind goes to these two trends where we're moving it from process orientation to outcomes orientation, and care delivery, we're moving from, the process orientation of doing X to somebody to outcomes, the value-based care model. And so these do converge in some way and align. And so I wonder if there's some where we think about what is visible and not visible for a physician's development to nurture that growth mindset, yet still be aligned to outcomes that are meaningful and important for patients. Because ultimately, I think, Danny, as you said at the outset, this is why we're all doing what we do, is ultimately to improve the health of people and communities. So it'll be an interesting convergence and see where these visibilities come in, I think, as we move forward. I'm going to move to a question actually from Glenn Woodworth, who's one of the co-authors of one of our manuscripts. It's a comment more, but I thought maybe we would comment on the comment, which is one that could benefit from standardization, is what competencies and frameworks are used in each specialty. So because only the milestones are mandated by the HGME and things like EPAs are up to individual programs, only a few specialties have agreed to these frameworks that are important inputs. And so just if you had a comment on that reality that, there's the HGME, but that's a fairly blunt when you think about everybody, the milestones, really it's these, it may be, my view is it may be up to I think we're going to need to engage specialties to push these models forward, but I'm curious if you have thoughts on it.
I feel like this is a plant for me and what we're doing in pediatrics, and an opportunity for me to really highlight it. In pediatrics, we have owned this, actually. We've developed EPAs for general pediatrics as well as all of our subspecialties. I think we have 17 subspecialties, and we have EPAs for each of them. And our community is totally invested. We will be using the EPAs as part of making initial certification decisions in 2028, so only a couple of years from now. And so that the question becomes, why EPAs? And what do we do with milestones and those being required by the ACGME? Happy to talk offline about how we are going to helping our community manage doing EPAs and milestones. I think we have a very good system that is set up. I'm happy to talk to people about that. It's going to make it very easy for people. And why EPAs? The competencies really provide great feedback for trainees when they have particular aspects that they need to be able to develop, right? But again, getting back to the CBME as a patient-focused way of doing this, we really think that EPAs are necessary because, you could take competencies like, can you hand over care? Are you good at interprofessional communication? Can you do an exam? And the answer could be yes, yes, and yes. Those are actually 3 competencies that go to our caring for a well newborn EPA, but you still might not be able to care for a well newborn. And so we really think if you want to answer the question, can you care for a well newborn? You have to ask the question, can you care for a well newborn? And that's why we're using EPAs, and our community is totally bought into that idea.
I'm gonna push us forward. We have a lot of questions here, so I don't know if we'll get to them all, but I'm going to try to get as many as we can. Next one's from Catherine Johnson. With respect to CBME and portability of data to support precision education and lifelong learning, what risks do learners at the transition points have as they move, will this into new learning environments? Does this introduce potentially bias? And one example I can think of is if you have some, this idea of I have the right to relinquish data, right, to have it gone. And so if you did poorly on something, but why should that be with you as you move to the next stage? Sally, do you have any thoughts on that?
Yeah, I mean, I think that's getting at the tension of normative and performance, right? Performance versus a growth mindset. And so I think somehow, in general, like I think I did like the first study of the milestone handover. We did it in emergency medicine, and other specialties have done some since then. And so that's the sense of that the students going into internship come with a handover letter that says what their performance is, and there has been resistance to it, as you note, because they don't want to be they don't want to bias or something as they come into the residency program. And so I think that's the whole culture change. So we've got to shift it to a growth mindset so that people are embracing it and it's not seen as punitive, and they see it as a way to grow. So I think it is a tension that we're dealing with.
Dan, anything you want to add to that?
No, I definitely agree.
I want to push ahead. I'm going to go a little bit out of order on some of our questions that we have here. There's a really interesting one. They're all interesting. There's one that jumped out to me from Elizabeth Kutcher, who asks about how precision education could help with professionalism formation. And professionalism has been a emerging and large topic in our profession. So I'm curious, and I'll think out loud a little bit as well, but I am curious if you had some initial thoughts on professionalism and the intersection with precision education.
So I think there have been books. I think I have one from like 20 years ago about how do you measure professionalism on my bookshelf, and it is to say it's a difficult measurement. And I also think I was in an interesting discussion yesterday about something, and we were like, is this really professionalism, or is this just a difficulty in organizational skills for the trainee? And so I think my sense of it is, as we can get more and more information coming into the data that comes in of did they do things, did I do something on time, did I respect the nurse, did I speak to them, and all of those different things that are professional, and as if it becomes just kind of the routine of data that comes in so that I can adjust with it, I would hope that it won't be weaponized, because I worry sometimes that we weaponize professionalism against medical students because we call their behavior unprofessional, and they weaponize mistreatment against administration in the medical schools. And so I think again, it's that growth mindset and having a culture, and then being very kind of clear, explicit, transparent about the behavior that we're seeing, and probably naming it as the behavior, right? You didn't get your thing in on time. That was disrespectful for the nurses, as opposed to just kind of, that was unprofessional, you're a bad person. So I really think that we've got to approach it in a different way.
Yeah, that's really interesting. I have a couple comments to me. I'll ask Dan to also jump in. Right now, professionalism is either people reporting an anecdote and their interpretation of it, or there are very clear metrics around did you close your notes on time, and specific things around encounters. And I do wonder how we can, I do wonder of the promise of potential of precision education looking at relationships and communication, because those are more and more data. Data captured, I should say. So there's communication in the OR that's captured on black boxes. There's obviously we all chat either through our EHR or through our phones, or so there's more and more, again, data related to communication and relationships. So I do think that there's potential, assuming the safeguard of weaponization, but there's potential of actually creating assessments here that we were unable to create before. Dan, did you have another thought on this?
Yeah, no, I mean, I at the risk of avoiding the question, I think that we should also do a little bit better job of selecting for this at the entry point of medical school. And I think that we can do a better job of it. So I think it'll make some of these things we're talking about easier if we can decrease the amount of it.
Yeah, that's great. There's a few more questions here. Maybe we'll do one more. So this is an interesting and a real problem as well from Julie Nyquist that came through. The adjustments and innovations are wonderful. The concern is that it really favors large institutions, and community programs will not have the resources to do the analytics piece. Can we elaborate on some of the plans to build these systems or how they may have access to them?
Yeah, I'll start with that one. Eric Worm, he does it on an Excel spreadsheet for years and years. Like that original data of long block, literally, it's an Excel spreadsheet. And so I think it is to say that you can do it if you're under-resourced. But I think the goal is to be able to export, share, propagate many of these things so that it is not just based on places that are being heavily resourced to be able to do it. And so I think that's the goal, and hopefully the promise of what we're doing is that if we create systems, precision education systems that we can share, then perhaps everybody can use them. Maybe I'm just an optimist, but that's what I see. I feel the same way. It's like I want to be able to do what everybody else does, and I may not be able to do what X does because I don't have that kind of money, but I should be able to do some.
Thank you. We are unfortunately at time. So I just want to first thank Dr. Santon and Dr. Schumacher for your time today and for taking the leadership along with your co-editors on this supplement, because I found it incredibly rewarding and educational to read. And I think it sets the stage for a lot of innovation and ideas and brainstorming that's going to follow as well. I do regret that we were unable to get to all of the questions. I hope we have opportunities for further discussion. I know the three of us would be happy to answer questions offline as well. So with that, I want to thank everyone for joining us this afternoon. We do encourage you to join us at our next ChangeMedEd webinar for a continuation of this discussion on content from the Academic Medicine Supplement. Our next webinar is Precision Education in Medical Education on the Ground Initiatives and Learning. This will take place on Monday, June 24th from noon to 1 p.m. Central. And you can register using the QR code that's on the screen right now or clicking the button below. And again, thank you so much for joining us. For more information on ChangeMedEd initiatives, please visit changemeded.org. And we wish everyone a very pleasant afternoon.